Diptaman.
Yes, sir. Good morning, sir.
Okay. So, good morning. Today we'll have a discussion on operative surgery, and how I will get a card of splenectomy. Then either you can go either for a open or laparoscopy. So we keep it separate. So today, Dr. Diptaman Nandi and Dr. Prashijit Basu, both are first year junior resident at MR Bangalore Hospital, will present this scenario. And with us today is Professor Shibojyoti Ghosh, who is Professor of Surgery at Calcutta Medical College. He will moderate. So Dr. Ghosh, we can start like exam scenario, initially with the open splenectomy with indications and others. So Diptaman will be presenting. Dr. Ghosh, please.
Okay. So during your examination, normally you are asked to draw a card for operative surgery, and usually examiner does not ask anything once you draw the card, and your topic will be there, and then you start talking. So let's assume that you have splenectomy on your card, and then present your case, present your operative steps. Who will be talking first, Dr. Diptaman or Dr. Prosenjit?
We can ask little about the indications and some.
Right. So normally it starts with the indications for the operation. So please, you start your operative steps as indications for splenectomy. So can you tell me about some of the indications for splenectomy, or the common indications for splenectomy?
Sir, good morning, sir. I am Dr. Diptaman Nandi, senior first year PGT, MR Bangalore Hospital of General Surgery. So the common indications of splenectomy are there are some medical indications, there are some surgical indications. Medical indications are some hematologic disorders like hereditary spherocytosis, primary hypersplenism, then thalassemia, leukemia, and there are some particular diseases like ITP, and there are some also surgical causes like splenic trauma, splenic tumors, splenic abscess, or any severe lacerated splenic injury.
Right. So basically, there are two types of indications. One common indication, rather. One is surgical indication, that is mostly due to trauma. And as you said, the other indications, surgical indications like splenic abscess, or say for splenic tumors. So these are the less common indications, but mostly for the elective splenectomy, these are all medical indications. As you said, the commonest being the ITP and the other blood dysplasias as you described. Okay, that's fine. So can you tell me what are the contraindications, or rather relative contraindications for splenectomy, particularly laparoscopic splenectomy?
Well, contraindications for splenectomy are
Laparoscopic.
Contraindications of laparoscopic splenectomy. The contraindications of laparoscopic splenectomy: patient hemodynamically unstable, and severe blood dysplasia.
Sometimes you need to do splenectomy for portal hypertension. Will it be feasible to do laparoscopically if you are going for a portal hypertension splenectomy?
No, sir. In that case, laparoscopy cannot be, is not feasible.
Difficult, relative contraindication. If you are very expert, you can proceed.
Yes, so usual contraindications laparoscopies are the very large spleen, which is very difficult to control laparoscopically, and as sir said, the portal hypertension. These are two relative contraindications for laparoscopic splenectomy. Now, can you tell me some steps for, or what are you going to describe, laparoscopic or open splenectomy?
He'll decide open.
Open. Very good. So I think all of you must be very much familiar with open splenectomy, particularly after passing your exam. So you'll be assigned emergency surgeon's duty, and you may encounter patients having splenic trauma. So there you should be should have sound knowledge regarding open splenectomy. Now, just tell me how you are going to do open splenectomy.
Suppose you are going for trauma.
Sir,
If it is trauma scenario, the incision and everything will be little different from a routine elective splenectomy. You are doing laparotomy for splenic trauma, and there is a splenic injury already diagnosed.
sir, it will midline or left, sir, initial as much as preoperative workup is possible, or some initial in case of emergency, if some initial investigations are possible or feasible, that can
Okay, you start with the
done.
steps. You start with the steps, anesthesia and other part you start.
So general anesthesia with intubation, then placing a sandbag below the left side of the behind the left side of the chest, then left midline or left subcostal incision.
No. I told you trauma. If in trauma, it will not be subcostal. Try to understand. If you are giving senior doing surgery for trauma, it should not be midline. It should be midline only.
So long midline incision, then.
No, you try to understand the point sir has explained, because in trauma surgery, it is not necessary that only spleen is injured. So there may be associated injuries to the intestine or the mesentery or other areas. So if you put left subcostal incision, so you will be committed to only splenectomy. You will not be able to explore the abdomen totally. So that's why it's very important in emergency. You should make a midline incision.
Midline incision. Then sir, exploration of the abdomen to see the internal structures, if any bleeding or if internal hemorrhage or internal laceration of any intestinal or organs are there. But if we mainly suspect the splenic injury, then after the initial inspection, then we will put one hand behind between the diaphragm and the spleen, and will mobilize the spleen towards the abdominal wound. Then after that, we will do the then sir. Then identification of the doing identify then after
Your sound is not good. Sound is breaking.
Right. So can you start from the mobilization of spleen again?
Which structure you need to divide to mobilize? What ligament you need to divide to mobilize if you are doing for trauma? Trauma and elective are different. In trauma, you should get onto the pedicle early because patient is bleeding.
Okay. Then sir, try to identify the posterior leaf of the linear ligament. And
which layer? Which layer? As you lift the spleen from diaphragm, you are reflecting and going to the cleavage between the spleen and the kidney. And you have one layer of linear ligament. Which layer is that?
Posterior?
Yes.
Right. So this is a posterior layer. This is mostly avascular. You mobilize that, and once you mobilize that posterior layer of linear ligament, then how it will help you or facilitate you?
Sir, doing this, we will be able to approach the splenic artery and splenic vein.
Yes.
So you can deliver the whole spleen into your wound. So you can take out the spleen into the wound. So that will be very
take out the
useful step. Then you try to identify the splenic artery and splenic vein.
As you divide, you can bring the spleen to the wound and you are right on the splenic hilar area. So what is there in the splenic hilar area? Three important structures. Three important structures in splenic hilar area.
Splenic vessels, splenic artery, splenic vein,
and
and
another important structure lying on the hilum of the spleen, which needs to be safeguarded. Any part of pancreas?
Yes, sir. Tail of the pancreas.
Yes.
Okay. Next, after that, what do you do? Which one you tie first? Artery first or vein first? If you can identify, then which one you will tie first? Artery or vein? You are not audible.
Diptaman, you keep your video off. Diptaman, keep your video off and answer.
So, okay, thing is that if we can identify both splenic artery and splenic vein, it is better to tie the splenic artery first, because that will reduce the blood supply to the spleen, and sometimes the volume of the spleen is also reduced. Spleen becomes decongested, and then we can ligate the splenic vein.
Hello.
Yes. Dr. Ghosh asked you which one will tie earlier, the vein or the artery. Diptaman, you are muted. Unmute. Yes.
The artery will be tied first.
Why? Why do you tie the artery first? Suppose you have tied the vein first. What is going to happen? You will be in problem. If you tie the vein first, what is going to happen?
Sir, there is a chance of damage to pancreatic tail. Or
No. If you tie the vein first, you have not occluded the artery. The blood will keep on coming into the spleen. Spleen will become more congested. So that is not the step. If you tie the artery, what is the advantage? There is an advantage of tying the artery first. Dr. Ghosh already answered. If you tie the artery first, what is the advantage? It's a large spleen. There is good amount of sequestrated blood in the spleen. So if you tie the artery first, the input is blocked. So some stagnated blood from the spleen will go back via the vein. So the large spleen may shrink in size. It will be easier to manipulate.
Okay, sir.
So tie the artery first and then.
So once the splenic artery and splenic vein are tied, then what are the next steps?
Sir, then sir, division of the gastric vessels.
What gastric vessel?
Yes, what gastric?
The short gastric vessels.
Yes, where are they? You are working posteriorly. So you have divided these two important vessels. Now, where are the gastrosplenic ligament?
Sir, there is a close proximity to the gastrosplenic ligament.
Where is the gastrosplenic ligament? Is it anterior or posterior?
Anterior, sir.
Yes. So there is a ligament called as gastrosplenic ligament. And that contains the short gastric vessels. How do you divide? How will you divide the gastrosplenic ligament containing the short gastric vessels? If you have good energy source, you can use a harmonic, or if you don't have, how will you tackle? Diptaman,
हेलो
हेलो
बोलो पेशेंट
हेलो हेलो
Yes, yes.
बोलो तो बोलो
यस सर
Tell us. How will you tackle the gastrosplenectomy ligament? Try.
So if you don't have any energy sources, suppose you're walking in a emergency situation in a district hospital, you don't have access to any energy sources, then how will you ligate or tackle the gastrosplenic or the short gastric vessels? Sir has asked these questions.
सर विथ 30
C0 it will just tear off.
PDS suture
C0 to tackle such bulky ligament. It's not 3-0. You describe it. You dissect, divide in between hemostatic clamps, and then ligate. That is what you do.
How many short gastric vessels are there normally? Is it a single vessel or is it multiple, many vessels?
So there are multiple vessels.
Yes.
Right. Normally, how many?
At that, there may be 3 to 4 or 4 to 5 short gastric vessels.
Right. So you have to serially ligate and on the both sides, on the stomach side and splenic side, then cut in between. Right. And
What precaution you should take? While dividing this, you need to take a precaution. Otherwise, you might develop a post-op complications. While you divide the short gastric vessels, at one point of time towards spleen, it becomes very short ligament. So what precaution you should take while you divide this? There is one important.
Sir, we should pancreatic tail.
You should. No, pancreatic tail does not come here. No. You should be taking care of the greater curvature of the stomach. Okay. Because if you are crushing the greater curvature source, you might cause injury to the greater curvature of the stomach. So that might undergo necrosis. That is one important complication of splenectomy. So you should take care of the greater curvature of the stomach, not to crush the greater curvature of the stomach. Okay, if you keep on going, you divide the gastrocnemial ligament. Still, spleen is not free. Something more is there, which is stuck in the spleen. You have divided inorenal, you have divided splenic artery vein, you have divided short gastrics. What else is now there?
Phrenicocholic ligament is still remaining.
Where is it? Phrenicocholic ligament is where? Caudally or cephadally? The lower border or upper border?
Sir, it is the upper border, sir.
Yes. So as you trace the gastrosplenic ligament, there is another ligament going from the splenic to the diaphragm. Divide that. While you come down, another ligament is stuck in the spleen to something else, to the colon. What is that?
Splenocholic ligament, sir.
That is linocolicophrenic. That is linocolicophrenic ligament. Which part of colon comes in relation to the spleen there? Which part of colon comes in relation there? Which? That is seen all the time.
Transverse colon.
Transverse colon. Near the linocolicophrenic ligament. Is it transverse colon? You are almost to the left corner. That area is what? That is colic flexure or splenic flexure, not transverse colon.
Right. That is known as spleen by the name of the spleen, splenic flexure of the colon.
Oh, splenic flexure. Oh.
Okay. So, once the whole spleen is removed, then what do you do?
Sir, sir,
So you check
we do a peritoneal toileting.
Okay.
And to see if any other injury or any gut injury or anything left, or any hemorrhagic bleeding points or any bleeding sources left behind. We will check that and then put a drain and then close the abdomen in layers and then give the skin closure.
Okay, so this is for trauma. Suppose you are doing it elective surgery, open elective surgery, and there is say moderate to large spleen. Then would you like to modify your incision and any other special precautions that you should take?
Elective splenectomy for suppose a hemolytic anemia. Would
Then
you
in
like
case of
to?
elective splenectomy, there will be some initial workup, including in pre-anesthetic checkup, and there should be vaccination.
Confined to the steps. Forget. Confined to the steps. The difference in surgery between a elective splenectomy and emergency splenectomy. That is the question.
Sir, in elective splenectomy, the incision will be left subcostal.
Good.
And
you can do my midline also, but subcostal is preferred. Fine.
And also remember, in case of large spleen, very large spleen, you have another option is thoracoabdominal. Sometimes it's very large and you can't get to the just below the dome of the diaphragm on the left side. So in such situations, left thoracoabdominal incision is also helpful, because when very large spleen, particularly as said the hemolytic anemia or any hereditary spherocytosis, there are some adhesions and of the spleen with the undersurface of the diaphragm, and sometimes these adhesions are
very vascular adhesions.
Vascular adhesions. So in such situation, in order to inspect all the structures, thoracoabdominal incisions are useful. Anyway, but you should keep in mind this is another option. Okay, then carry on.
Then sir, the other steps are more or less similar to in emergency.
No, there is another approach. No, there is another approach. There is another approach. If you can go by a different approach. What is this alternative approach? Rather than going by linear ligament approach. That is followed also in laparoscopic technique.
Because here spleen is not bleeding, this is elective, right? In emergency, in trauma, the spleen is bleeding, so you'll have to do something to keep control the bleeding as early as possible. But here the spleen is large, that's the problem, but it's not bleeding. So you can do the surgery in a more methodical and scientific and precise way.
So you have not read that. What you can do is you can divide the gastrosplenic ligament first. Once you divide the gastrosplenic ligament, where will you identify the splenic artery? You got my point? You have divided the gastrosplenic ligament. Yes. You are in the lesser sac. So where will you identify the splenic artery? You know? What is the relation between the splenic artery and the pancreas? Where is the splenic artery? Splenic artery runs along the upper border of the pancreas. Splenic artery runs along the upper border of the pancreas. So if you go by gastrosplenic approach, you can get early into the splenic artery at the upper pancreas. And as we already discussed, if you like it, the splenic artery, a large spleen can shrink to some extent. Okay, so once you have done that, the vascularity is reduced. And then come to the hilum of the spleen. What is the relation of the splenic vein to the pancreas?
It lies lower border of the pancreas.
Lower border. Are you sure?
Near to the tail of the.
It's a long course from tail to the neck, where it becomes a portal vein. What is the relation between the pancreatic surface and the splenic vein? Artery along the upper border. The vein is
Yes.
behind the pancreas, behind the body of the pancreas. Okay. In the tail region, it is the hilum of the spleen.
And how this splenic vein is formed? Is it directly comes out, single vein directly comes from the hilum, or there is something else?
How does a splenic vein forms? Spleen has got segments. Spleen has got multiple segments.
Right. So there may be multiple, tributaries from the spleen, and that comes out through the hilum and ultimately finally joins to form a single vein, that is splenic vein. So you should keep in mind the anatomies. All the anatomies you should know very nicely. Otherwise, you'll be in trouble during surgery, right? If you operate or ligate the vein very close to the hilum, so don't think it is a single vein and you have ligated and everything is fine. So otherwise there will be chance of torrential bleeding.
And regarding the artery, what do you mean by magistral type of splenic artery and distributive type of splenic artery? That is also important. You know the distribution of the splenic artery. What is magistral and what is distributive? जितना कुछ पढ़ना चाहिए. You should read some books. The splenic artery may be a single trunk going to the hilum and then dividing, because spleen has got segments. Or the splenic artery may be divided much away from the hilum, and the individual branches goes into the different segments of the spleen, because your surgical technique will vary. If it is a magistral type of splenic artery, one ligature close to the hilum will be enough. You put 3 ligatures, divide in between the 2 proximal. But it's a distributive type of splenic artery, you need to ligate the individual branches. That is important, because otherwise, as Dr. Ghosh said, you ligate one branch, other branch will keep on bleeding. So there are 2 types of splenic artery. One is magistral type, when the whole trunk is single and it divides at the hilum. Or it's a distributive type, when the branching occurs early and the individual branches enters into the splenic segments.
Right. So this is very important steps that is different from splenectomy for trauma and elective splenectomy. So other rest of the steps are more or less same. Now,
Post-op complication, Prashanjit will take. Let us, Prashanjit, describe the salient steps of laparoscopic splenectomy. Prashanjit. Prashanjit? Prashanjit, you come up.
Hello.
Yes. Prashanjit, we have discussed the indications. We are not going to that. So we will be discussing is splenectomy feasible laparoscopically?
Sir, should I start from indication and contraindication?
No. Indication you have discussed. Indication you have discussed.
Okay.
So splenectomy is possible laparoscopically. Okay.
Yes.
And
sir.
Earlier, what maybe what is relative contraindication for laparoscopic splenectomy?
Sir, relative contraindication are some hematological malignancies such as chronic myeloid leukemia and chronic lymphocytic leukemia. And absolute contraindication is splenic size more than 25 centimeter and portal vein thrombosis. These are absolute contraindication.
If you have portal hypertension, difficult.
Yes, sir.
Okay. And so just tell us, describe the salient steps of laparoscopic splenectomy.
Sir, preoperative
patient, anesthesia.
Okay, sir. Preoperative preparation includes blood coagulation as a factors assessment and arrangement of blood, and pre-vaccination. In case of elective surgery, we should pre-vaccinate the patient 2 weeks prior to surgery with a Haemophilus influenza type B and pneumococcal vaccine and meningococcal C vaccine. And then we should perform the gastric compression by putting a rice tube, and prior to surgery we should do CT scan to assess the size of the spleen. Then for anesthetic we should prefer general anesthesia, and in patient position, the patient position should be in a right lateral decubitus with the bean of bag put in the below the right flank and right axilla, so that the there is hyperextension and field of operation will be maximized.
What are the different port positions?
Sir, we have 3 ports. First, optical port, which is along the mid clavicular line, 2 centimeter below the costal margin, and parallel to the costal, 2 centimeter below the costal margin along the mid clavicular line. This is 10 mm port. And posterior axillary line, 2 centimeter below the 11th costal cartilage and parallel to it. And third port is 5 mm port, which is lateral to xiphisternum and parallel to the costal margin. We have 3 ports.
Where? On the right or the left?
So left side, on the left side.
3 port is not enough for splenectomy. 3 port is not the standard description for splenectomy. You need more ports.
Sir, we have
3 port become right and left working with the surgeon, and the optical port.
Yes, sir.
Another port is required for retraction.
Yes.
Yes, sir. It may be put in epigastric region, sir, for retraction purpose.
And if you need to retract the stomach for gastrointestinal ligament division, that is in the left subcostal
Inside
area.
dorsal aspect, yes, sir, subcostal region.
So the 3 port is not the standard port. People put 4 or 5 ports.
Yes, sir.
How do you start?
Yes.
How do you start the operation?
So once pneumopolyp is created, what are the next steps for mobilization of the spleen?
Sir, we have to free the splenocholic ligament and phrenicocholic ligament so that the inferior pole is freed and it can be mobilized. Then,
Motion, you try to understand. You are doing laparoscopy is relative contraindication for splenic trauma because patients are stable. So most of the time, laparoscopic is you are doing for elective splenectomy.
Yes, sir.
The elective splenectomy steps are a little different, and most of the students find is a gastrosplenic ligament approach fast.
Yes, sir.
What is that? So, what do you do?
Sir, we introduce from optical port, and we first of all we search for any accessory spleen. If they are, we should search for that. Then we go for dissection of the gastrosplenic ligament and secure the short gastric vessels with harmonic scalpel, then we dissect the splenorenal and splenophrenic ligament, and
no. Yes. You are dividing the gastrosplenic ligament. What comes next? Don't jump to splenorenal ligament next. Once you divide the gastrosplenic ligament,
so we divide the gastrosplenic ligament and we enter the lesser sac.
Yes.
And we secure the short gastric vessels with this harmonic scalpel.
Yes.
And then, sir, we proceed to dissect splenorenal ligament and
Before going there, you have to have something to be tackled. We have discussed in open also. Once you are in the lesser sac, you try to find the splenic artery.
Yes, sir.
Where do you find it?
So it is along the superior anterior border of the.
Don't confuse anatomy. There is nothing called anterior border in the pancreas.
So superior border of.
Yes.
Superior border of pancreas.
Where? Where you should take the artery?
Sir. Hello.
Yes. Where do you take the artery? It should be close to the splenic hilum.
Yes, sir. It's close. Sir, So we find for the splenic artery, and it is near the superior border of the pancreas, and we secured the splenic artery with the
What is the
endovascular.
technique? What is the laparoscopic technique for tackling splenic artery?
Sir, it can be tackled with endovascular stapler, or we can use.
Stapler is not the standard description. We have different types of clips. Have you heard of any other clip like apart from Liga clips?
Sir, some hemostatic clips are available.
Yes.
We can use them.
It is described as hemolock.
Hemolock, yes, sir, yes, sir.
So you dissect the splenic artery and apply hemolock clip.
Yes, sir. And alternatively we can. Yes, sir.
Hemolock clip is not available.
Sir, alternatively we can use some energy source with a bipolar device.
No. Alternatively, it should be ligated.
Yes, sir.
It is inside. Ligate and divide.
Yes, sir. Number 0 seal can be used to.
Yes, splenic artery is difficult to be taken by energy sources. It's not a usual recommendation.
What is the maximum diameter of a vessels that can be sealed with energy sources, various energy sources, more or less same, all the energy sources?
Sir, I don't know, sir.
It's 7 millimeter on an average, 7 millimeter, right? Okay. Can you name other than as you said?
Harmonic takes up to 5 millimeter, and the ligashute takes 7 millimeter.
Right.
Yes. If you have a ligashute in hand, you can seal 7 millimeter, and large splenic artery may be more wider. So in this case, either hemolock clip or ligature.
Ligature can be used, sir.
Yes. And then once you have done that, you retract the stomach upward, come to the hilum of the spleen. What do you do now?
Then, sir, we secure the splenic vein.
Before that, splenic vein is little behind. Something is in front. What you have to do? Some structure is lying in front of the splenic vein.
Sir, tail of pancreas. Tail of pancreas.
So you dissect the tail of pancreas.
Yes, sir. We should descend the tail of pancreas and lift the inferior pole of the spleen so that tail of the pancreas can be preserved. And
you now apply clip or like in the splenic vein.
Splenic vein, yes, sir.
And now you have more ligaments to divide.
Yes, sir.
Muscular part is taken care of.
Yes, sir.
Muscular part is taken care of. Now you have something more to divide.
Splenorenal ligament and splenophrenic ligament is divided up to the left crus of the diaphragm is visualized. Up to that part we should divide.
And at the lower border, there is the ligament going from spleen to
splenocolic.
Yes.
Colic ligament, sir.
The linocolicophrenic ligament. Yes. Lower spleen, the splenic flexure, and then to the diaphragm. So that ligament you have to divide.
Yes, sir.
Spleen is free. How to take it?
Sir, we then introduce a 15 mm endo catch bag from the 12 mm port and apply to the spleen. Then we morcellate the splenic tissue and taken it in pieces. The splenic tissue.
Morcellator is not available. You don't have a morcellator.
So ovum forceps can be used for morcellation.
You manage only with these 10 millimeter ports, or sometime you might need to have something else. With the 10 millimeter port, putting this ovum forceps, taking the spleen out will be hell of a job.
Yes, we use sometimes we create 15 mm port to taken out the spleen.
There is standard description. You can make a small 5 centimeter incision, either superficial or fenestrial incision.
Fenestrial, yes, sir.
Okay, you should not fight. If we have a 20 centimeter spleen, taking it piecemeal out to this 10 millimeter port will be a very difficult job.
Yes, sir.
Right. So after the spleen is out, then complete the operation?
Sir, we search for any bleeders in splenic fossa, and we secured if there is any bleeders in splenic fossa.
Okay.
We must.
And whatever the drain in a elective operation, would you like to put drain or no drain?
We put a drain, sir. If we suspect any injury or to tail of pancreas or any other structure, we put the drain. Otherwise, there is no need to put drain, sir.
Okay, so if you suspect injury, particularly the injury to the tail of the pancreas, then you may need to put in a drain. Sometimes drain itself causes injury to the tail of the pancreas. Remember that.
Oh,
Okay,
yes.
so there are controversy and they depend on the level of confidence whether you put in drain or decision. So tell us about the complications of splenectomy.
Yes, sir.
Post-op complications.
Yes, sir. Post-op complication includes hemorrhage from
Yes.
the splenic fossa side, or splenic artery ligature may be slipped out to leads to bleeding
So what
or
is
hemorrhage.
bleeding? Bleeding is one complication. What else?
Then, sir, overwhelming post-splenectomy infection.
See, that is late. Before the immediate post-op complications. Bleeding is one.
Right. So any
What else
operating
is there?
steps or any operative complication, when you are asked to try to divide it into, as sir said, there's peroperative complications, early complication, and late complications. Right. Always try to describe that way. Okay. For hernia, say for hernia, for thyroid surgery. So always classify it that way. Now tell us about the early or the immediate post-operative complications. So one you said bleeding. What else?
Sir, splenic accessories spleen may be left out.
No, that is not a complication. That your failure to identify. Immediate complication. What can go wrong? One is bleeding. Second is you have injured the pancreatic tail.
Yes,
In
sir.
advance, you have injured the pancreatic tail. What may happen in the post-op period?
Sir, injury to the tail of the pancreas, injury to the
What will happen?
That will lead to what?
That will lead to, sir, pancreatic fistula.
Good.
Yes.
As I said, while dividing short gastrics, you might have caused ischemia to the greater curvature.
Yes, sir.
What may happen in the post-op period?
So injury to the greater curvature of the stomach, and that
Even if there is no obvious injury,
yes, sir.
vascularity may be compromised. So there may be necrosis.
Yes, sir. Necrosis.
In the greater of the stomach. So patient will have all fluid features of gastric perforation, signs of peritonitis.
Yes, sir.
Okay.
Yes, sir.
And
what about the lung?
Sir, there may be pulmonary thrombosis.
Complications are chest complications are very common following splenectomy. Is abdominal surgery just below the diaphragm.
Left-sided pleural effusion may occur, sir.
For that, what is the most important complication?
Subphrenic abscess may be formed.
Lung complications. Patient is not breathing properly because of pain.
Sir, post-op atelectasis.
Yes, that is the first thing you should say.
Yes, sir.
Post-op atelectasis.
Basal atelectasis.
Yes, sir.
So other than the gastric necrosis, as sir said, and perforation, any other stomach complication that can happen in post-operative period following splenectomy?
Sir, gastric fistula, sir.
No, that sir already said. So acute dilatation. There is sometimes the acute dilatation of the stomach. Right.
Yes.
So a patient will be, you'll have to put in Rice tube and all. So that is another complication of acute dilatation. So these are the early complications.
Yes, sir.
About the late complications.
Sir, overwhelming post-splenectomy infection is late complication. Venous thrombosis may occur. Pulmonary thrombosis.
For that, you have said you will vaccinate the patient.
Yes,
patient
sir.
should undergo vaccination.
Vaccination.
Is
Sir,
elective pre-op?
in elective case, we should vaccinate the patient 2 weeks prior to surgery, and
Yes.
in case of emergency surgery, immediate
Yes.
post-op as
Yes.
soon as possible.
What are the blood changes that occurs following splenectomy? Changes in the blood.
Sir, thrombocytosis may occur, sir. Increase in platelet count in case of ITP.
Hey, not even right. Once you take the spleen out, there may be
Yes,
some increase in platelet count.
platelet count, yes, sir.
Yeah.
Thrombocytosis may occur, and
Only the platelets.
sir,
What component get destroyed in spleen? What blood component get destroyed in spleen?
RBC, sir. Polycythemia may occur, sir.
Polycythemia is again a very high WC count, but the whole, you see, if you are doing for pancytopenia,
Yes, sir.
pancytopenia happens in sphenic enlargement. So this
Yes.
count may improve. The WBC may increase, the RBC may increase, platelet may increase because the spleen is not there
Yes, sir.
for sequestration of these blood elements.
So in one word, that is called pancytosis, right?
Pancytosis, yes, sir.
All formed elements of the blood that will go up.
Yes, sir.
Count of these formed elements will go up. Right.
Is the risk of DVT increased?
Yes,
Is
sir.
the risk of deep vein thrombosis increased?
Yes, sir. Chance of deep vein thrombosis increases.
Yes. So you should take care. If you are doing splenectomy, the risk of deep vein thrombosis is increased. We should take care. How do you take care? What are the measures?
Sir, from post-op POD 0, we introduce low molecular weight heparin. And
Talk of first of mechanical. First talk of mechanical prophylaxis, then come to chemical prophylaxis. Mechanical is
compression pneumatic
stocking
stocking
or compression stocking it. Active exercise, early ambulation.
Yes,
So
early
talk of this and then talk of pharmacological.
low molecular weight heparin. Yes, sir.
So usually it's not given on the day 0. It's after 48 hours, right? Otherwise, all your bleeding site will start bleeding. I mean, surgical sites will start bleeding, right?
Yes, sir.
Tell us something about this prophylaxis guidelines. So do all patients need prophylaxis?
Sir, prophylaxis must, sir.
Young, healthy patient, right?
Yes, sir.
No comorbidity. Would you recommend prophylaxis for that patient also, particularly in Indian scenario?
Sir, low molecular weight heparin.
No. Talking about antibiotic prophylaxis or the vaccine prophylaxis.
Yes, sir. It is recommended for, sir, in all ages, sir. For younger age, in less than 2 years, we should not give the pneumococcal vaccine, but above 2 years, we should prefer the vaccination, sir. Pre-op vaccination, sir.
No, there are certain recommendations for young children less than 5 years, all immunocompromised patient, old aged patients. So
yes, it is penicillin prophylaxis, sir, up to 10 years for less than 5 years, and above that we should go for 16 years.
Right. So these group of patient, high risk group of patient, it's recommended to have this profile antibiotic and vaccination prophylaxis. But otherwise, there is some controversy. Different countries have different guidelines. So healthy patient, right? No comorbidity. So whether you give prophylaxis or not. And other than this, what are the other patient counseling during discharge? What are the things you will tell the patient during discharge following splenectomy? Keeping in mind the possibility of this OPSI. They should carry a card, right? So everything should be written on there.
Yes, sir.
And they should also carry some antibiotics, right? In case of fever, persisting for more than 48 hours, right? And they should be advised to attend the emergency department of any hospital if that fever does not subside within 48 hours, right?
Yes.
So
Yes,
they
sir.
should be.
Prasenjit, do you
Yes,
need
sir.
to assess the hepatobiliary system in patient who has got a situation of chronic hemolytic anemias? If so, why? Hepatobiliary system.
Yes, sir. Chronic chronic hemolytic anemia may leads to hyperbilirubinemia. Indirect bilirubin may rest in chronic hemolytic anemia, sir.
Surgically, talk of surgical importance. There are a lot of patients who has associated gallstone disease with hemolytic anemias. These patients may have pigment stones.
Yes, sir. Yes, sir. Pigment stone
Patient may have
is the
gallstone.
common.
Patient may have CVD stone. So
Yes, sir.
you should always keep in mind that patient who is undergoing surgery for chronic hemolytic anemias, you should exclude associated pigment gallstones or CVD stones.
Yes, sir. We should
It's not very
go.
uncommon.
Yes, sir.
Dr. Ghosh, anything else? I think we have gone
Yeah,
through.
also, you should keep in mind that there are now the newer technologies, like robotic surgeries. So these are also the another options. So this can also be, splenectomy can also be done, particularly elective setup can be done by robotic surgery.
Yes.
And these are and you should keep updated about the recent guidelines on prophylaxis following splenectomy. So these are things that you should update yourself.
Yes, sir.
Dr. Sugar Maiti, good morning. Any comment? Maiti sir. Okay, any last comment, Dr. Ghosh?
Yes. So as I said at the beginning, that you must be aware about the various steps of particularly the emergency splenectomy, because once you pass out, you are given the duty of the emergency surgeon. So you might have to perform this splenectomy in emergency setup individually. So be familiar with the anatomy, as Sarah said repeatedly, about the anatomy of various splenic ligaments, about the anatomical location of the splenic artery and splenic veins. So these are very important steps during a surgery, and should also take care about some prophylaxis about antibiotic and the other vaccination things that you should keep in mind. So these are very important regarding splenectomy.
Okay. Thank you, Prasenjit. Thank you, Dr. Diptaman. Thank you,
Thank
Dr.
you,
Ghosh, for good session. Thank you.
Thank you, sir. Thank you.
Okay. Thank you.
Thank you, Professor Shah. Thanks a lot.
Thank you. Thank you, Dr. Ghosh.
Thank you, sir.
Thank you.